Hi, my name is Denise Freire and I'm going to talk about partial oral versus intravenous antibiotic treatment of endocarditis. Definition. Endocarditis is an endocardial infection that affects internal lining of the valves and cardiac cavities caused by Streptococcus, Enterococcus faecalis, Staphylococcus aureus, or Staphylococci and who were being treated with intravenous antibiotic to continue intravenous treatment or to switch to oral antibiotic treatment.
Patients with infective endocarditis on the left side of the heart are typically treated with intravenous antibiotic agents for up to 6 weeks. During the initial phase of hospitalization and treatment, patients often require intensive care and close monitoring. After this period, many patients remain hospitalized to complete intravenous antibiotic treatment. In this randomized non-inferiority trial, 400 adults in stable condition who had endocarditis on the left side of the heart caused by Streptococcus, Enterococcus faecalis, Staphylococcus aureus, or coagulase-negative staphylococci, and who were being treated with intravenous antibiotics were randomized to continue intravenous treatment or to switch to oral antibiotic treatment. In all patients, antibiotic treatment was administered intravenously for at least 10 days. The primary outcome was a composite of all-cause mortality, unplanned cardiac surgery, embolic events, or relapse of bacteremia with the primary pathogen, from the time of randomization until 6 months after antibiotic treatment was completed. In the intravenously treated group, the primary outcome occurred in 24 patients, as compared with 18 patients in the orally treated group, with a between-group difference of 3.1 percentage points that met non-inferiority criteria. This trial showed that in medically stable patients who had endocarditis on the left side of the heart, caused by Streptococcus, E. faecalis, S. aureus, or coagulase-negative staphylococci, a transition from intravenously administered to orally administered antibiotics was non-inferior to continued intravenous antibiotic therapy. Full trial results are available at nejm.org.
Applications in medicine. Patients with infective endocarditis on the left side of the heart are typically treated with intravenously administered antibiotic agent for up to 6 weeks. During the initial phase, intensive care and close monitoring are often needed because the majority of complications, including death, are seen during this phase. For a large proportion of patients, the main reason for staying in the hospital after the initial phase is to complete intravenous antibiotic treatment. Therefore, if oral antibiotic treatment might be safe and efficient, part of the treatment period for patients in a stable condition could take place outside hospital without the need for an intravenous catheter. The oral regimens consisted of 2 antibiotics from different drug classes with different antimicrobial mechanism of action and different metabolization processes to reduce the risk of monotherapy.
Next comes the differential diagnosis. So we have 4 diseases. The first one is the rheumatic heart disease. The second is the atrial myxoma. The third one is the Liebman-Sachs endocarditis. And the fourth one is the non-bacterial thrombotic endocarditis. So first in the rheumatic heart disease, when the rheumatic, basically it is a complication of the rheumatic fever. When the rheumatic fever is relapsing and is not treated, it basically leads to the damage of the valves inside the heart and the inner layer of the heart, that is the endocardium, that is known as the rheumatic heart disease. Then comes the atrial myxomas. So atrial myxomas are basically the non-cancerous development of a cyst or a mass inside the atrias of the heart, and they are basically present on the atrial walls or the walls that are dividing the both atria. So they lie there. Then comes the Liebman-Sachs endocarditis. It is a non-infectious endocarditis that usually occurs in combination with or with the SLE. Then comes the non-bacterial thrombotic endocarditis. It is also non-infectious disease, and we have already discussed it in the pathogenesis that a small thrombi are formed due to the collection of the collagen and the fibrin to cover or repair that damaged valve or the wall due to the inflammatory process. So, and once the bacteria is added with this non-bacterial thrombotic endocarditis, the person gets infective endocarditis.
Pros and cons. Pros. Oral antibiotic treatment could take place outside hospitals without the need for an intravenous catheter. Cons. The primary outcome was composite of all-cause mortality and planned cardiac surgery, embolic event, or relapse of bacteremia with the primary pathogen from the time of randomization until 6 months after antibiotic treatment was completed.
From Great Britain. He has just finished presenting not a trial necessarily, Mark, but an observation about what has happened in Great Britain after the discontinuation of all prophylactic antibiotics. So, Mark, this is a curious, funny kind of observation that you have done. Tell me what you actually did.
Well, what we did was in March 2008, the National Institute for Health and Care Excellence stopped antibiotic prophylaxis in the UK. And what we've done is we've used hospital data to look back at all the patients in England to see who was discharged with infective endocarditis, both before the change and after the change. And we've also looked at antibiotic prescribing practices during that time to estimate the impact of the guidelines.
Okay, I actually was at your presentation, which was terrific. And then I will tell you that for the audience that this is a relatively straight line until 2008, and then it takes a quick upward curve. Now, is that a fair resume of what you found?
I think that's a fair resume. We found two things. We found firstly that the rate of prescription of antibiotic prophylaxis really fell away, and we only had about 10% of the level after 5 years that we had before the change. And we found an increase in the rate of change in the number of people getting infective endocarditis. So there's an increase over the baseline, more than we would have been expecting.
And did you split that up into high risk and not so high risk patients?
We split it up into high risk patients as per the sort of AHA criteria, and also into all the rest to see if we could differentiate any impact on these two groups.
Okay. So what do you think about this? I mean, is this just chance? Is this something that's real? Do you have any clue as to how you sort of winnow out what's going on?
We certainly need to do a lot more analysis. We've demonstrated that there's been a temporal association, but we certainly haven't demonstrated a cause-effect relationship. We don't think practice needs to change at the moment, but we do think that more attention needs to be paid to this.
Well, I will remind everyone that the U.S. guidelines say it's okay that high-risk patients continue antibiotic prophylaxis. But even in the U.S., we've been cautioned about using antibiotic prophylaxis in routine patients having dental work, for example, and so forth. So I guess the question is, Mark, how do you get to the bottom of this? I mean, if this is real, this is important. But if it isn't real and just noise, then we can forget it. So what's the next step?
I think the next step is to see if we can design a randomized clinical trial that we can actually complete.
Well, we're talking about hundreds of thousands of patients.
We are potentially talking about a six-figure number of patients followed up for probably 5 years at least.
Well, obviously that's the right way to get to the bottom of this. If any of you have lots of millions of dollars out there, send them to Mark. But thank you very much for being here.
Thank you. It's a pleasure.
Issue applied in Ecuador. In Ecuador, for the treatment of endocarditis, the intravenous route is preferred because of its maximum efficacy. Commonly used drugs are inhibitors of cell wall synthesis such as genemycin or vancomycin.
Hi there. welcome to Hippo Shorts. In this segment, we're going to talk about infectious endocarditis. Specifically, we're going to address the antibiotic guidelines as published in the 2017 update put out by the American Heart Association and the American College of Cardiology. So what are we going to take a look at? We're going to address who gets antibiotics and when. So the WHO basically are patients that are at high risk. Who are these high-risk individuals? Folks with prosthetic heart valves, patients with a prior history of infectious endocarditis, patients with unrepaired cyanotic congenital heart disease, or patients with completely repaired congenital heart disease with prosthetic material or devices. We cover them for the first 6 months after surgery. Also, patients who have had congenital heart disease repaired with prosthetic material and have residual shunts or valvular regurgitation either at or near the site of their patch or device. Lastly, patients with heart transplants with valvular disease are also covered with antibiotics. What is specifically administered? We give these folks amoxicillin, and that's administered as a single 2-gram dose given 60 minutes prior to the procedure. Patients that are allergic to penicillin, they can get cephalexin, clindamycin, azithromycin, or clarithromycin. Okay, when do these patients get antibiotic prophylaxis? Well, dental procedures, specifically those that involve manipulation of gingival tissue, periapical region of the teeth, or any perforation of the oral mucosa. In addition, patients that are going to have some invasive respiratory tract procedure that involves incision or biopsy, as an example, tonsillectomy. Additionally, patients with surgical procedures involving infected skin or musculoskeletal tissue, here, those folks, you want to cover them with some type of anti-staph antibiotic coverage. Lastly, antibiotics are no longer indicated for patients with gastrointestinal or GU procedures or in patients with orthopedic hardware undergoing some type of dental procedure. That wraps it up for this Hippo Short. For more information, come on down to hippoeducation.com and we'll see you next time.
Conclusion. In patients with endocarditis on the left side of the heart who were in a stable condition, changing to oral antibiotic treatment was non-inferior to continued intravenous antibiotic treatment.
Antibiotic prophylaxis is the use of antibiotic in order to prevent bacterial infection. Because of the emergence of bacterial resistance and antibiotic toxicity, the indications for using this antibiotic as a prophylaxis is limited to certain conditions such as before surgery, before any dental procedure, and medical conditions such as recurrent urinary tract infection. In dental procedure, it is recommended in order to prevent infective bacterial endocarditis. So coming to the surgery where we use the maximum as a prophylaxis antibiotics. So the commonly used antibiotic are cephalosporins first and second generation, which include cefazolin 1 gram, cefuroxime 1.5 gram. Is used, and only one dose is recommended, and the duration, how long you will give, and the time of administering the antibiotic is very important. Ideally, it is recommended 30 minutes before surgery. Only one dose is recommended. In case if the surgery extends beyond the expected time of more than 2.5 to 3 hours, one more dose is recommended. Post-operatively, the antibiotic should not be continued unless it is recommended because of any infection or prior colonization, it is recommended. So commonly used antibiotics are for example, orthopedics, it is first and second generation cephalosporin. In case of alimentary canal surgery, for example, appendicitis, we know the flora involved, intestinal flora involved gram-positive, gram-negative organism and anaerobic organism. So in order to cover all this flora, it is recommended to give, apart from that, give either quinolones can be given or anaerobic coverage metronidazole or clindamycin is recommended. So we at Apollo Hospital, we strictly follow antibiotic prophylaxis. We do regular monitoring of antibiotic prophylaxis, and we do an audit, and whatever results are communicated to the respective stakeholders. So to summarize, in order to prevent emergence of antibiotic resistance and the toxicity of antibiotic and the cost involved, it is very important to restrict the use of antibiotics. Thank you.